Good evening, everyone. I am Dr. Harmeet Singh, consultant and head of accident and emergency at Max Healthcare Vaishali. And I am also the organizing chairman of this trauma series that is continuing since November. And in a couple of weeks, we are going to end this series. Today with us we have Dr. Dorothy, who is consultant emergency medicine at Max Healthcare Vaishali. She is going to talk on eye trauma. So as we all know that eye trauma is very important. People are not aware, even the doctors working in emergency medicine, they are not aware how to handle eye injuries, eye traumas. So let us invite Dr. Dorothy to talk on pre-hospital, in-hospital, emergency care, and also chemical and physical injuries of eye.
Hello, good evening, everyone, and welcome back to the trauma series. Myself, Dr. Dorothy from Max Vaishali. Today, we'll be discussing about eye trauma. Eye trauma. Today, we'll be talking about the eye trauma, which will be including the introduction, epidemiology, classification, anatomy and the physiology, evaluation, pre-hospital care, management, and the complications. Eye trauma. It is the number one ocular emergency, leading cause of blindness, irrespective of age, sex, and geographical status. 40% is the reason of monocular blindness. Male and the young age group is greater in incidence rate. Efficient referral expected from the professionals. Every person should know about the importance of the quick response to an ocular injury. Prophylactic measure is always better than management. The WHO program for the prevention of blindness suggests that annually approximately 1.6 million blind from injuries, 19 million with unilateral blindness or low vision, and 2 lakh open globe injuries. It also leads to the resultant loss of vision, which leads to psychological, economical, and the professional crippling of the patient. A brief discussion regarding the ocular anatomy. Eye sits in a protective bony socket called the orbit. It is attached to the 6 extraocular muscles in the orbit. The extraocular muscles are attached to the white part of the eye called the sclera. This is a strong layer of tissue that covers nearly the entire surface of the eyeball. The bony component of the orbit, it is mainly of the 7 bones: frontal, zygomatic, maxillary, sphenoid, ethmoid, and lacrimal, and the palatine. Eye is composed of the anterior chamber and the posterior chamber. Anterior chamber is the front part of the eye between the cornea and the iris, filled with aqueous humor. Posterior chamber is between the iris and the lens. Talking about the physiology, light is focused in the eye through the clear dome-shaped front portion of the eye called the cornea. Light passes through the vitreous humor onto the retina, which is composed of the photoreceptors, rods, and the cones. Retina sends light as electrical impulses to the optic nerve to the brain that transmits impulse to the visual cortex, that is the part of the brain responsible for our sight. Classification of the eye trauma. Classification according to the nature. That is the physical trauma, thermal trauma, chemical trauma, and the radiational trauma. In physical trauma, we'll be discussing about the perforating, non-perforating, and the blunt trauma. Chemical trauma, that is mostly of the acid, alkali, and dyes. And the thermal trauma, that is of the heat and the cold. Radiational trauma are of the lasers, ultraviolet rays. And the classification of that is from the Birmingham Eye Trauma Terminology, devised a classification for the ocular trauma which is acceptable worldwide. Mechanical trauma are of 2 types: open globe injuries, full thickness of the eye coats is included, and the closed globe injury, which includes the injuries without full thickness of the eye coats. Open globe injury is further divided into laceration and rupture. Laceration is divided into penetrating, perforating, and intraocular foreign body. Closed globe injuries are of contusion or concussion, lamellar laceration, and the superficial foreign body. About the eye trauma assessment, First, we'll be dealing with the history part, which should be as detailed as possible. In history, we'll be including whether there is sudden or the gradual change in vision since trauma has occurred, whether associated with pain, diplopia, and photophobia. Time and nature of injury is important. Mechanism of injury, which can be missile, blunt, or foreign body, or chemical, etc. Whether it's accidental, intentional, or self inflicted, whether it has occurred at home or the workplace, use of glasses were there or protective wear. In case of mechanical trauma with a foreign object, size and the shape of the object, distance from where it has come, exact location of the impact, cases of foreign body, that is, what is composed of the foreign body, contamination, origin and the exact mechanism of impact, and single or multiple. Injuries from the animal, type of animal and the injury, try to locate the animal to test for transmissible diseases. Chemical injury, nature of chemical, check pH if sample is available. Past ocular history will be including pre-existing ocular diseases, if there is any, previous ocular surgeries, visual acuity prior to the incidents, and the immunization history, which is important, whether there was tetanus immunization prior, any treatment taken for injury in details, or intraocular or periocular appliances were present, intraocular lenses, scleral bundle, glaucoma drainage implant. And the systemic examination is the general condition of the patient. And the assessment of the ABC, airway, breathing, and the circulation, that is important for the eye trauma because it will include the facial trauma as well. And we need to secure the airway and the circulation and the breathing part, associated head injuries or fractures, any systemic condition that may need urgent intervention, proper documentation and the medical legal case registration. Examination of the both the eyes is important, and the documentation, whether do you have photographs or were there any evidence present, and gradually plan for the repair. In investigation part, we'll be including the routine hematological investigation. Radiological imaging, it will include the plain radiograph if CT and MRI is not available. X-ray, orbit, AP and lateral views, and PNS to rule out orbital fractures, intraocular foreign body and intraorbital foreign body. CT scan, computer topography, indicated if bony involvement is suspected, the importance of the axial and the coronal sections. Indication is open globe injuries, posterior segment visualization, suspected intraocular and intraorbital foreign body and hemorrhage, and orbital fractures. MRI, which is indicated for soft tissue lesions, suspected vascular lesions, intraocular pathology, and optic nerve lesions, non-magnetic intraocular or intraorbital foreign body. It is contraindicated in metallic foreign body, pacemaker, and implants. The recent advance of the ultrasound for the eye trauma is the best resolution for the posterior chamber, 0.1 to 0.01 mm. But the extreme caution is in cases of open globe injuries, which is preferably avoided. Indication for ultrasound is vitreous hemorrhage, peripheral vascular diseases, retinal tear and detachment, choroidal rupture, suprachoroidal hemorrhage, scleral rupture to visualize the lacrimal gland and the soft tissues and foreign bodies. Talking about the first aid, that is the pre-hospital event for the other patients, which can be managed at home. The few tips which we should all know: thorough eye wash for foreign body or chemical injuries, cleaning and dressing of the wound. Do not give pressure on the eyeball in case of globe rupture. Apply a shield in case of open globe injuries. Tetanus immunization and systemic analgesic and antibiotic. This is a raccoon eye, which is caused by the blunt trauma. It is self-limiting if no other injuries exist. Be sure to open the leads apart to examine the eye structure and the motility. Lead laceration. Trauma to the lead, which can be diagnosed by the orbital fat, usually protrudes to the septal laceration. Fat in the lead laceration confirms the diagnosis. high incidence of globe penetration and intraocular foreign body, high risk for orbital sylvitis. General principles of repair. Clean the wound, remove the foreign body, careful handling of the tissues, careful alignment of the anatomy, lid margin, lash line, skin folds, etc. Close in layers. Timing is important. It is ideally within 12 to 24 hours of injury, but can delay up to 1 week, depending upon the patient's factors or gross swellings. Anesthesia should be used under GA or LA, depending on the patient's condition. Repairing procedure. Superficial laceration without gapping can be sutured with 5 or 6 or black silk. Remove after 5 days. Lead margin laceration carefully aligned to prevent notching, allowing with 5 or silk suture. Close tarsal plate with fine absorbable suture. Place additional marginal silk suture. Close skin with a multiple interrupted suture. Laceration with tissue loss. Primary closure and may also need a lateral cantholysis. Canalicular laceration repair. Repair within 24 hours. Locate the approximate wounds and bridge the defect with the silicone tubing. Leave the tube in situ for 3 to 6 months. This is a picture of the lead, repairing of the lead lacerations margin. Orbital blowout fracture. A patient often presents with the anophthalmos, diplopia, impairment of the eye movement, orbital emphysema. CT scan should include the axial and the coronal cuts. The patient is with the orbital blowout fracture is often associated with the facial injury. So we can, for the airway protection, we can give the jaw truss for airway management. In case of cervical injury, cervical collar is indicated. And for the treatment, we would go for the surgical repair, subciliary incision. Subciliary incision, periosteum is elevated and orbital cell contents are free. Defect repair and synthetic material, periosteum will be sutured. Ruptured globe. Trauma leads to the corneal or scleral disruption and extravasation of the intraocular contents, can lead to irreversible visual loss and ophthalmitis. Management is by the stop the examination immediately. Do not delay, cover with eye shield, do not patch. CT head and orbit to evaluate for facial and orbital injury. Patient should be kept for NPO for further processing and tetanus immunization. Start systemic antibiotics and repair plan. Complication are hypotony, patient decreased vision, hyphema, loss of anterior chamber depth, teardrop, pupil which points towards the laceration, and subconjunctival hemorrhage. This is a picture of the penetrating and the ruptured globe caused by the golf ball. These are the pre-hospital care that we can do for the shielding the patient of one eye without putting any rough patch with the things which are available and the under sterile condition. Traumatic cataract. Trauma to the anterior segment complication is one of the traumatic cataracts seen in contusive eye trauma, usually repaired in a secondary operation. It is reported in 11% eyes with closed globe injuries. Investigation by the ultrasound B scan to rule out retinal detachment, tear, and intraocular foreign body. If possible, a plastic intraocular lens is inserted instead of the damaged lens. Treatment of amblyopia is crucial. Hyphema. Blood in the anterior chamber. Sometimes hard to diagnose. Complaint of mostly blurring vision and pain. Complications are elevation of the intraocular pressure and rebleeding. Can be diagnosed with the ultrasound scan to rule out the posterior segment involvement. Tropical prednisolone is indicated and cycloplegic. Wear eye shield, propped up position, and bed rest. Surgical trabeculectomy and vitrectomy in severe cases. Subconjunctival hemorrhage. First, we need to rule out the causes of the subconjunctival hemorrhage, that is mostly Valsalva, coughing, sneezing, vomiting, and anticoagulants. Treatment is wait and watch, lubricating and antibiotics, eye drops, and oral vitamin C. Traumatic luxation of lens. Lens drawn away from the site of jonular rupture, anterior segment asymmetric. Lens may dislocate in anterior chamber, posterior extruded. Patient often complains of diminution of vision, monocular diplopia. Treatment is by the spectacles, contact lens, and myotics. Lens in the anterior chamber is mostly treated with anti-inflammatory and anti-glaucoma. Surgical capsular hooks, photoemulsification, and photofragmentation. Corneal injuries that includes the abrasion, laceration, and ulcers. Patient is often presents with the intense pain, redness, photophobia. Clinical manifestations include the lead edema. Treatment is by the debride any loose epithelium with a wet cotton swab or sharp blade. Diagnosis by the fluorescent staining to see the epithelial defect. That is called the Siedel's test. Broad spectrum antibiotics, tear substitute, and the cycloplegic. Avoid patching of the eye. Avoid contact lenses. Re-examine patient after 24 hours. Extreme eye pain is relieved by lidocaine drops. Siedel's test. Concentrated fluorescent dye is used to identify whether corneal laceration is sealed or not, to assess the presence of aqueous humor leakage from the anterior chamber. In this, the fluorescent dye is dark orange but turns bright green under blue light after dilution. This is indication of the aqueous humor leakage, which is diluting the green dye. Positive indicates laceration. Posterior chamber trauma, the major is retinal detachment. Retinal detachment, it is the separation of neurosensory layer of retina from the underlying choroid and the retinal pigment epithelium. Sign and the symptoms that includes the warning signs: black coming down over the visual field, bright flashes of light, photopsia in front of the eye, the patient often feels, increasing floaters, decreased visual acuity. Diagnosis by the fundus photography, that is the larger instrument than the ophthalmoscope, or a ophthalmoscope is used, and the ultrasound for further injuries. Surgical method is cryopexy and laser photocoagulation and vitrectomy. Foreign bodies. Corneal foreign body is often metallic foreign body following work injury, foreign body sensation, tearing, redness, or painful eye. Careful slit lamp examination for the exact position and the depth. Removal under slit lamp with 26 gauge needle. Magnetic removal for a deeply embedded metallic foreign body. Residual rust ring may remove with sterile burr. Antibiotic ointment with cycloplegia or NSAIDs. Chemical burn. Treatment should be instituted immediately before taking history. Lead should be retracted and fornices to be swabbed for particular matter. Emergency treatment, saline copious irrigation for 15 to 20 minutes until neutral pH is achieved, may range from a few liters to many liters, more than 8 to 10 liters. The initial treatment is only irrigation and irrigation and irrigation once pH is established. Sterile topical steroids, first 7 to 10 days to reduce the inflammation. Topical and systemic ascorbic acid to enhance the collagen production. Topical citric acid to inhibit neutrophil activity. Topical and systemic tetracyclines and to inhibit the collagenase and neutrophil activity. Cycloplegia to improve the comfort. Talking about the severity of the chemical injuries, it is graded in 4 grades. Grade 1, that is for the excellent prognosis, which clear cornea, no limbal ischemia. Grade 2, good prognosis, cornea is hazy but visible iris details. Limbal ischemia less than 1/3. Grade 3, guarded prognosis, hazy cornea with no iris details. Limbal ischemia 1/3 to half. Grade for opaque cornea, limbal ischemia, more than half. Eyes are window to the soul. Let's keep them safe and manage them well. Thank you.